I'm the descendant of horse thieves out of Quebec. My great-grandfather was a missionary doctor in the Aleutian Islands, and his son was a doctor and professor at the University of Vermont. My father was poster child for ADHD, and then there's me. I was born and raised in Vermont, went to the University of Vermont, went to medical school in Vermont, did my residency in Kalamazoo, Michigan, but went back to Vermont and was a primary care pediatrician up north near the Canadian border in a little town called Enosburg Falls. And I was the sort of the outlying, it was a small group of pediatricians, but I was out in the boonies. But I was a primary care pediatrician for about 15, 17 years, and I started to deviate, I guess is the right word, into developmental behavioral medicine, and actually was able to get boarded in it, being grandfathered in rather than having to take a fellowship. And after working for a small agency in Vermont that had 3 schools for kids with autism in little towns in northern Vermont, we proved to the world that you cannot make a living as a developmental behavioral pediatrician, and they eventually weren't able to subsidize me anymore, so I needed to get a real job, and that's how I ended up in Kentucky about 2 years ago. So that's usually part of my standard talk that I give to people. I tell them that developmental behavioral pediatrics, which is a subspecialty of pediatrics, it's fairly new. I think it was 1969.
Oh, really?
I usually tell people it's harder than it looks, and that's one of the reasons there's only about probably 700 now in the United States total.
Did you find the prevalence of autism was pretty, percentage-wise, is similar in Vermont as is in Kentucky and other places? Or I'm just curious, that remote region.
Yeah, I think in my experience as a primary care pediatrician, so when I first started back in 1986, autism wasn't even really on our radar. I mean, I remember maybe seeing a video during residency that, oh, at a lunch conference, oh, here's a kid with autism, oh, you know, oh, okay. But it wasn't really on our radar. And as a primary care pediatrician, it wasn't really, I honestly don't remember for the first 10, 15 years thinking, oh, this child has autism. That never really came up till about probably 10 years ago. Became more aware of, ooh, there's something out there that is called autism. And then looking back, trying to look back at all the patients I'd seen over the years, going, ooh, I wonder if Johnny, you know, back in 1988, was he on the, would autism explain how we presented at that time? So in the end, I think the prevalence is the same everywhere now. So the big question that people always ask is there more autism now than there was back then? And I don't have a good answer for that because it wasn't even on our radar. So I think a lot of kids back then were going to be, if they were nonverbal, they were going to be classified as an intellectual disability. But if they were verbal and quirky, they were going to be labeled something else. Or they have ADHD or they're quirky. But as time went on, started coming up with, ooh, this fits a distinct pattern. So usually when I give talks at hospitals or whatever, the title of my talk, it's harder than it looks, in that, so once there's so few of us that specialize in this, what that leads to is overwhelming, crushing demand. It also is difficult in that, once again, you can't make a living doing it, so that isn't going to attract a lot of people to do it. And that is sort of based on how reimbursement is made to doctors. So reimbursement schedules are set up by surgeons. So you get paid more for doing procedures. So, but as opposed to, well, if I'm going to sit and talk to someone for an hour about their behavior, about what's going on, you know, we'll get paid this much, but if I take a bean out of somebody's nose, I get paid this much. So one of the jokes in our office was if someone came in with a bean in their nose, we would fight each other for it. And then the second thing was, well, if someone comes in with a behavior concern or developmental concern, why don't we put a bean in their nose as they come in the door, then take it out, and then be able to charge for the bean, because you could spend, you know, a long period of time trying to understand the behavioral problem and not get reimbursed. So as a primary care doctor, where we would sometimes see 30, 40, 60 kids a day, if someone came in and they were having, oh, by the way, Johnny's doing this and stabbing the cat, and okay, I have about 30 seconds to figure this out because I have 10 people in the waiting room that are coughing or, you know, spewing different body fluids all over the place. I don't have a lot of time.
So are you saying that the way the model works, the only way to really monetize your services is in the higher education level? I mean, in a college setting? That's the only way for it to be something that you could make money at? Not in a
Right. So when I decided to go into developmental behavioral pediatrics, I put all that, I studied, you know, I'd get up early, study, because I had to take a test. So I had to sort of learn all the nitty-gritty stuff. Yeah. And then so when I finally passed and I had worked a while in the field, and I went to the chairman of the department at the University of Vermont and said, I'm going to be doing developmental behavioral practice in my own little practice. And he said, it'll never work. You know, I was like, oh, thank you for your support. You know, he says, can't do it. And so basically is in a primary care, in a like private practice setting, especially if you're going to take Medicaid, yes, or fight with insurance companies, you're not going to be able to make a living. Yeah. So the subspecialty of developmental behavioral pediatrics is one of the lowest subspecialties in terms of reimbursement. And then conversely, it also has one of the longest, if not the longest, waiting time. So if you look all the specialties, you know, cardiology, pulmonology, kidney, whatever, the longest wait times are developmental behavioral pediatrics and rheumatology. And then the lowest paid is usually developmental behavioral pediatrics. Because once again, it's time consuming, but you don't get paid for time, you get paid for procedures, and we don't really have a procedure unless I stick beans in kids' noses when they walk in the door. So that puts a crimp in people looking at subspecialty or specialties. So what do I want to be when I grow up? Ooh, do I want to be a developmental behavioral pediatrician? So I have a slide in my little showcase. It was from a resident blog saying, oh, it's a cool thing, it's an interesting field, but if you're going to go into it, either you take care of rich kids and rich families and charge them cash, and don't accept insurance or you go work for a university. So that sort of throws a monkey wrench into at least having physician level people in the field.
Well, that explains a lot to me because I have a granddaughter who has autism that has huge behavior problems. And she's 18 now, and we have yet to really get good help ever. So that explains a lot. And, you know, they're quick to want to put her as a ward of the state. They're quick to want to send her to an institution, the health field. But they're slow to want to try to get her behavior help. And even when we get behavior, ABA, so-called behavior help, they're more concerned about being paid for their paperwork than they are coming in and teaching her how to behave. I mean, you know, I'm just saying, that's
One of the other
explains a
frustrating
lot.
things as a developmental behavioral pediatrician is, for the most part, our interventions or treatments is specialized instruction. So we're not surgeon, we can cut something out or cut something off, or or put something in, or we have medicine for things. For developmental behavioral medicine, most of the treatment is specialized instruction. So once again, as a physician, that's frustrating because we don't often have control over that. If you've ever been around surgeons, they have a certain type of personality because they have control of things, because they can cut it out so they can do things. The problem or the challenge with developmental behavioral pediatricians is, once again, it's specialized instruction. I can't deliver that, so I have to rely on other people or other fields to do that. And sometimes that's like herding cats. No, it's always like herding cats. And it's not always the cats you want to herd, I want little fluffy, friendly cats, and sometimes it's big snarly cats that aren't very cooperative. So that's another reason people don't like to go into the field, because you don't have a lot of control. And that also sort of goes back to what you experience, or especially have experienced in the past, with the big centers. The big centers are mostly evaluatory in setup. They'll do a $64 million evaluation. The problem is, after the evaluation, they go, bye. It's a diagnosis and a handshake. That's how some people put it. And so what we're struggling to do in our little department, or mini department, is evaluation's important, but what's more important and also more difficult is what are you going to do about it. And so, as I think everybody can vouch for, the hard part is, after you come to some understanding or sort of finality, this is what we're going to call it. The hard part next is, what are you going to do about it? And that's where things sort of like fall apart. Because you don't necessarily have a medical home to run things from. Primary care doctors usually aren't very comfortable managing things, so you're going to go see somebody else, maybe that's 3 hours away, and expect them to manage things. And so what we're trying to do here at the University of Kentucky is come up with more of a medical home model. But we've sort of have already maxed that, not quite maxed it out, but it's, I probably officially started seeing patients in January of 2014. So it went from, I don't have any waiting list, come on in, to now that we're getting 40 to 50 referrals a week.
Oh my gosh.
And we can, and at most, if we're really good, we can do 6 to 8, if we're really good, to 10 evaluations a week. And now we're starting to see the problems with, so I want to, when I see people and I say, yeah, okay, come back in a month, because I want to change your medicine and we're going to tweak things, and I want to see you back in a month, the front office comes back and goes, you don't have anything open for 3 months. Well, that's, you know, because the way, if you, quite frankly, if you're going to do it right, if you're going to tweak things, you want to, you don't want to send someone away for 6 months and, because if it's not working after a week or two, you want to be able to change it or fix it. So that's a growing challenge.
Explain how the medical home model that you're establishing works. I mean, it would be the medical home of a patient, but what all does that home?
Well, so I call it the governmental model. So the governmental model is, so you have a patient, Johnny. So the governmental model is Johnny, that's the United States of Johnny, or the Commonwealth of Johnny. So we have a president, those are the parents, or the co-presidents. Under the president, there's 3 cabinet level divisions. There's the medical division, the educational division, and the community division. What's key to the governmental model, though, is something I call the chief of staff. The chief of staff sort of ties everything together. So the chief of staff sort of has their finger in, or has knowledge of everything is going on. So typically what happens is the parents, the chief of staff. So not only are there presidents, they're the chief of staff. But this is a very complicated
Government.
Universe. So I'm going to say 110% of parents are totally overwhelmed or don't have the skill set or knowledge or experience or whatever, because they're parents. They're not social workers, and they're not medical, they're not neurologists, they're not behaviorists, they're not insurance adjusters. But for the most part, in the typical world, the parents end up being the chief of staff. So what the key to our little model is the chief of staff. So I have 2 chief of staffs right now. I have a nurse practitioner who we got hired. She's wonderful. She was in a family care center for many years, so she has lots of experience. She's not specifically trained in developmental behavioral, but she's trained in being tenacious. So when you say, oh, you need to find this or this, she'll find it.
Good.
And then the other chief of staff, our official chief of staff, is Melanie. So she was, so the thing, so what she's sort of done as a volunteer for free, we're now trying to figure out, no, you're going to get paid for this. So, and I'm gonna go out on a limb and say this is pretty unique for, if not Kentucky, but the states and or the world in terms of this setup, because most of the setups are evaluation based. So you go wherever, you go to Cleveland or Boston or Yale, and you do the $64 million workup, and they say, okay, you have elemental P, QS, PDD, elemental whatever. We're going to give you anywhere from 1 to 6 pages of recommendations, or books, movies, websites, techniques, I'm gonna send you home. So what we're trying to figure out is, no, this is your home, and you're gonna follow up here, and we're gonna monitor and manage you. And we're gonna see you on a routine basis, and boy, if you're having problems at school, we're going to volunteer to go to the school and be, once again, there's 3 cabinet levels. So there's the medical, so I'm the medical, but there's the educational, how do we get that person sitting at the table, and there's the community, what other services in the community. How do we get all those people at the table and have a team? But that as we move forward, that's going to take a lot of change. Well, it's going to have, because one of the things I will say, I'm quite somewhat discouraged. When I was in Vermont, if I had a child come in, a parent brought a child in with some behavioral issue at home and or school, talk things over, and we'd go, okay, who do you work with at school? They'd give me the name. I'd call the school and say, oh, let's have a team meeting. And they would go, yeah! And we'd go to this, I'd go to the school, so didn't get paid for it, so that's one of the reasons I'm here, but we'd go to the school and we'd have a team meeting. And some of the schools, we even set it up so we'd go once a month. And we'd go over our little flock. And they were and sometimes if I couldn't go there, all the teachers would come to my office. So we'd have, 10 people. We'd have the local bluegrass people and the speech and language and the first steps people. We'd have meetings. I've found that has not been very easy to set up here. The schools have been very we don't want anybody sort of messing in our turf. And it's been anywhere from sort of polite non-response to we don't want those doctors coming in here and telling us what to do. So that's been very discouraging because these conditions, not just autism, but ADHD, intellectual disabilities, are very complex. And just like any other medical, quote-unquote, medical condition, if you're going to have your heart surgery, you're going to have your kidney transplanted, you don't just have one person sitting there doing everything. You have a team of individuals. So you have anesthesiologists, you have, the cardiologist, you have the intensive care person, they all work together. So in order to correctly approach these issues, you need a functioning team. 'Cause I'm not a teacher, so I'm right off the bat going to say I'm not qualified from that standpoint. I'm not necessarily a behaviorist. I'm not a speech and language therapist, but I can bring my sliver to the table, but it's a sliver. I need the help of all those other people. So it's been frustrating trying to figure out how to set that up. We've gone to a few team meetings at schools, and some of them have been, what are you here for? And then there's been a couple that, wow, this is great. So we're hoping that, sort of hoping that it spreads, because if it spreads a lot, then we're going to have to hire about 27 more Melanies. But
Yes.
so,
How many?
27.
How many schools have you been in?
I'm going to say 5 or 6.
Yeah, mostly elementary, I think.
I've gone to middle school once. But where I was in Vermont, I was in a very rural area of northwestern Vermont. And so my supervisory union had 5 elementary schools and 2 high schools. And so I basically went to I went to all those schools once a month for a regular team meeting. And we went over our flock, so that there'd be a team from the school, whether it's the school nurse or psychologist or the counselor and whoever. Each school is different. We'd sit down and we'd often meet with parents for part of the meeting. The other part of the meeting was, how's Joey doing? How's Susie doing? There was one school that, oh, no, we don't want you. We'll take care of our own. And they didn't believe in, well, it was sort of driven by the principal. But for the most part, it was very, I thought, very rewarding working relationship. And I can honestly say there's a lot of kids that if we didn't have that in place, they would have ended up in alternative settings or foster care placement or things like that. But because we all sort of got our act together, or the act together, that, oh yeah, we sort of figured this out. So.
It's been really neat to be it's been tiring, I'll admit, but it's been an honor, because the one thing I always say is helping them get connected to ASBG, or if they're in another part of the state, and if there's a support group there to get connected to other families or, people that have kind of been on the journey, that they just happen to have a child that's a little bit older, and they've been doing it a little bit longer. And I think that's been a real positive thing, because there's a real, just in my own humble experience being involved with this group, I think it kind of saved me a couple times when I thought I was going to fall apart, and I just had this group of people that I could complain to, bitch to, bring to meetings with me, whatever. But it was like it was a community that kind of got me through some things that I didn't think I could.
So we're trying to figure out how to make that a formal, because what I tell people now, when we go in as our little team sometimes, I'm Dr. Larrow, but the most important person in the room is going to be your family support person, which is her, or sometimes it's Carol, because they're the ones that are going to bird dog the interventions or the supports or tie things together that as a physician I don't have, that's not in my skill set, or I don't have the time to do it, unfortunately. So, quite frankly, to me, the most important person on our team is the chief of staff. It's not the doctor, it's not the educational person, it's not the, well, I shouldn't say it's the parents and the child, but the next most important person is the chief of staff. So the hard part is, and I'm sure we're going to buck this down the road, is what she does is not reimbursed. So all, the hospitals or whatever that do this, they're always going to look once again at the bottom line, and we run into that. Are you generating revenue? Are you generating revenue?
No. I'm finding the university is supportive in schools.
But how can we, what do you need help with to start showing that we generate revenue? Because it will. Right now, the way that we have the broken system, the money's going to that broken system. It's
Right.
not going to the children that have the needs.
Right.
Or the people that have the needs. So what can we do
Well,
as a group?
so we can look, I think you can approach it from sort of the, I don't know if the word's philosophical or systems, or approach, or you can approach it from concrete. So we approach it from concrete. We need a space. So right now, the University of Kentucky, the Child Development Clinic, or whatever you want to call it, I like to call it an orchid clinic, and I can tell you what, I can explain that. But our developmental clinic is 2 tables about the size of this table in the middle of the general pediatric clinic. So we often have at this table 6 providers. So we have a doctor, a nurse practitioner, Melanie, 2 residents, and the nurse. So now that we're on the electronic medical record, so we have 6 of us all sitting there with a computer, and then we have piles of charts and records and stuff, and we're all sort of crammed in, and then we're using the general pediatric exam rooms, which are about the size of this. We have a mom and dad and grandma and the little child and their 2, and the baby, and we're in the little room.
That's true, and us.
Okay,
With the
and there's Ashton. He's don't eat the paint. Don't eat the crayon. Oh, okay. So we don't have the space, and so and there's different things we can bring up. The kids we're seeing are not sick. They're not ill, but they're being brought into a clinic where people are sick. This is a sick clinic,
And
so
kids are
they're
getting
sitting at.
shots all the time.
Yeah, so one problem is they're sitting out in the waiting room with, different body fluids flying all, And then also, sometimes it sounds like you're in Guantanamo because, you see a nurse head in with like 4 shots, and, they, no, and so the little child that you're, evaluating is sort of, what the heck? What's going on? So it's not a user-friendly space. So we really need our own space to be able to do, a good evaluation and to do it efficiently. And so, because one of the things we're running into, sort of in the field, is there's a sort of controversy versus multi-specialty evaluations. So when I say multi-specialty, so you're going to go someplace and you're going to have the doctor, and you're going to have the psychologist, you're going to have the speech and language, you're going to have the OT, and you're going to spend, a few years ago you'd go for 2 days. But once again, trying to come up with an efficient model, we just need a sort of a big room that has toys and stuff, and so as one of us interviews the parent, either you're also observing the child, or you have the other person, whether it's like today the resident did the history, I played with the kid. That's what I get paid for. Stack blocks and that's a job. But we can't do that in a room that's this big, because it's just you're sitting on top of each other. And once again, I don't think it's user-friendly to have healthy kids sitting in a room with sick kids. I guess you're promoting business, but you're generating revenue. And once again, if you have kids screaming and yelling because they're getting shots and stuff, we're already dealing with children that they don't like to go to the doctors, and so. That's why I don't wear a tie and I don't use a stethoscope, because when I walk in the room, if I came in with my tie and my white coat, a lot of the patients would whoa, they would freak. So I try to look like the janitor, successful.
I don't have to wear a tie.
Yeah. And I get flack from that from some of my colleagues, ooh, why didn't you wear, because I'm going to go in the room and my goal is to get down on the floor and play with a kid. And I'm not going to be doing that in a white coat and a tie.
It'd be hard to get a white coat, especially one of those long ones.
Plus, we were taught where I was taught pediatrics, the problem with a tie is it's what we call a foamite, because they're dragging it and blowing their nose on it and everything else, so it's just, that's why a lot of pediatricians wear bow ties, 'cause so they don't have to drag stuff. So,
In 1992, when my daughter was diagnosed as having a developmental disability, developmental delay, UK had a grant
Yes,
for an interdisciplinary infant and toddlers evaluation center.
I took.
Because, yeah, she went there.
Right.
So
So did we.
can you
Jake
pull
did too,
that
it
paper
wasn't-
up?
It wasn't at UT,
Just like-
I think it was.
change the names and the dates and say this is
So-
what we need?
so the dilemma is, once again, is how do you develop a system that is self-supporting? So, we're not on it to make a profit, but you gotta be able to pay the people's salary, and you wanna be able to pay good salaries to get good people. So how do you come up with a system that is financially efficient? And so,
Because they did have
so
a
what
space as you
so there's
described.
ways of getting grants and things like that, but what I've seen all the time in my career is, oh yeah, so the university just got this nice grant, but it only goes for 2 years, and so you have 2 years, and at the end it's like, well, yeah, geez, you know,
Too
we
bad.
can't afford this, we can't do this, so it shuts down after 2 years.
But, you know, I mean, U of L has the Weisskopf.
I know, that's
I
what
mean,
I
why
was gonna
can't we have
say.
something
How are
like
they
that?
doing it?
Yeah.
How is
They
Well,
don't
so-
do anything but evaluations. We just had her 2-year-old evaluated there, and it was a fantastic space. It's like what you're saying you
Yeah.
need, but they don't do anything
Well,
but
But
evaluations.
I think
so
part of
they're
it
generating revenue.
is because whoever Weisskopf is, I don't know if it's George Weisskopf or Sally Weiss, so someone at some point donated
Yes.
a big chunk of money, they
Right.
built a building, and so they have that space.
And they have the contract with First Steps, because that's how James ended up there.
Ah.
Right, so there's a lot of politics behind things, because where you can get money from this, so, and I'm the first to admit that I am not a political, that's way over my head, that's not in my portfolio. So there's stuff even now going on at the state level, which, recently that bill that didn't pass, and the autism czar isn't going to be stationed here anymore, and the commission's doing this, and the commission's being moved, or who's moving, First Steps is being moved into the
That's
commission.
what I had heard.
Yeah, so there's all stuff going on, but what I tell people is when I've been to a couple of those meetings, Melanie dragged me to one.
She doesn't.
I've been trying to get her.
But, so the way I look at it is all the generals are talking, and they're talking about strategy and, looking at the big picture. But I consider myself a foot soldier, and I'm sort of sitting at the back of the room going, I don't have a gun. I have a gun, and, we'll get to you later, or we don't have money for a gun, but we're gonna, so.
But we got these nice bullets you can have.
So,
But just
so
get the
the,
money to the kids, that's what I want to see, so the services go to the children.
so the hard part is, so there's a lot of battling for money. So there's monies out there, but, the genetics department and the metabolism department, they're fighting for money, the renal department, the cardiologist, everybody's fighting for money. And once again, so there's a lot of stuff, because some of those subspecialties are revenue generators. Ooh, they make lots of money for the university, or they're flashy.
Well, as part of the medical team, referrals to other parts of the UK hospital area, neurology, is that part of it, which is revenue generating?
Oh, if I-
child needs
if
a
I-
neurologist, refer the child to
Yeah,
neurologist
so
or
if I
gastroenterologist.
refer them to speech and language, or
There's no pediatric, there
There's no
wasn't.
pediatric OT, so there's PT, but we rarely have PT referrals. Those often come in through they come in through the Shriners, sort of. Someone has gross motor problems, but we don't have OT, we don't have ABA.
But those other medical fields, isn't that part of the model though, where they come and they get an evaluation from you? I know our first visit to a neurologist was occasioned by our evaluation, our initial evaluation at age 4.
Yeah. Was there a concern for seizures or?
Mhm.
Yeah. So, yeah, so that can happen. Oh yeah, you need to see the neurologist, or I send people off to the geneticists or the metabolism people. So yeah, that hopefully generates revenue, but it also can be abused in the sense that, so I've seen some centers, so someone walks in the door, oh, okay, we're going to send you the psychologist, the speech, the neurologist, and the geneticist, just because we can. And so they're generating revenue. Did that person need to go to genetics or speech and language? No, but that's way of maintaining, finding a way of generating revenue. And so that's one of my concerns with multidisciplinary things. So if I have a multidisciplinary team sitting with me, and Joey walks in the door, and I'm like, oh, okay, I don't need you, and I don't need you. Go ahead and have a cigarette and get back to us later. That's a waste of their time, and that's inefficient. So I just participated in a clinic that's sort of a pilot for a multidisciplinary clinic. And so there's 4 doctors, and a bunch of nurses and stuff, and we saw 6 kids. You know, but that's 3 doctors and 6 kids, and it was a little bit more than an afternoon. But in the end, the question is, do you need 4 doctors to see, because someone's got to pay those, because it was the way it was set up, all those doctors were going to get paid regardless. So where's that money coming from? Taxes.
The broken system.
Well,
The broken, I mean,
yeah, well,
it's like you're sending these referrals, I mean, in the multidisciplinary system, what I'm hearing, you're sending them all these referrals to a broken system where they don't talk to each other to help the person.
right. So that's that once again trying to figure out how to develop a team, but do it in an efficient manner. That's the challenge.
And finding the portals, because the one thing that and this is me just being new at this, but there's a wonderful resource through Medicaid called EPSDT. I know I keep bragging about this, but EPSDT, and in ours, if I understand that correctly, the feds and Medicaid have now said that these different services for autism need to be covered. But and many of the folks that have a medical card or whatever, you have to join what's called an MCO, like Coventry Cares, and I don't know all the names of it. WellCare and places like that. And then what I'm learning from being around Dr. Larrow and Carol is that they'll say no. You know, they'll order some kind of testing or therapy of some sort, and theoretically it's supposed to be provided, and it'll become like an obstacle to be able to access that service, and it's like, okay, so just very...
Well, it seems like their job is cost containment,
Yeah.
so these are set up to contain medical costs, but how do you contain medical costs? You contain them by saying no. So when we go, oh, I'd like to do this medicine, or I'd like to get this test, they go, no. We're containing costs, but it's like, so, but like, today was a prime example. A colleague was trying to start some ADHD medicine on a child that was 5 years, 10 months. And whoever they were said, no, because you have to be 6. So actually he was going to be 6 in 2 weeks.
Yeah.
No, he can't have it, he's not 6.
What?
Really? But but that's the whether that's the impression that if that's the impression I get from the system is that it's a cost containment system, and the way they do that is by saying no, and it's not based on medical logic. It's based on financial logic. Like, okay, we have a contract with this drug company to supply these medications, so you can have those, but any others, we're not going to let you do, unless you follow our, we're going to come
You
up with.
gotta try something for so long.
Yeah, you got to
Yeah,
try.
right.
You try the useless medication and prove that it
Yeah.
Prove
doesn't
it
work.
doesn't work, and then,
Then you can try the appropriate medication.
Right.
Yes.
so in the meantime, the child goes back to their school, goes back to their home, and then they have all the things that can
And
happen.
a couple of months go by.
Yeah, and it just,
And the medicine, maybe they'll have to try Strattera first. Well, that's got to build up in your system.
Takes 4 to 6 weeks. Yeah.
And then you don't know if that's working, and there might be side effects, and you go get something else for the side effect, and it's like then you don't know if the Strattera is working or not. But yet, if you had something like a little Adderall or something like that, you know right away if it's going to work. But I'm just saying that those are.
So that's another reason people don't like to go into developmental behavioral medicine, because so much of the time you're trying to do things with one hand and one leg tied behind your back. Or the insurance company is going, tell me what I'm thinking. Because you'll go, okay, what medicines should I try? Can I try this? I'm not going to tell you until you've put it through, and then okay.
It's like when I would apply the old days of applying for medical insurance, and they keep raising your premium because of this thing and this thing and this thing, which I thought was pretty healthy. But I forgot to mention that I took fluoxetine. Well, they came back and said, oh, we pulled up your medical records and you're taking fluoxetine. I'm like, well, if you knew all that, why were you asking me? Why didn't you just look at my medical records? But anyway, that's just that type of thing. So what will work? What do we have to do?
So at the concrete level, we need a space and we need more people. Because right now I'm not satisfied that our wait time is 6 months. So when people call in to get an appointment, I have a concern that my 21-month-old has autism. Like, we'll see him 8 months from now.
Right.
That's
exactly
Well, that's what it
happens.
was at Child Evaluation Center.
well, yeah, and that's the way.
Even though.
Yeah,
So we're not quite as bad as Wyckoff or Cincinnati, but we're getting there. We're going as fast as we can, but so we're going to need more people. But I had to donate one kidney and other body parts to get Carol hired, and I'm actually quite shocked that they allowed us Melanie. So, but they are supposedly looking for another developmental behavioral pediatrician, but there's not a lot of them around, and that's another reason we need a space, because if someone comes in and goes, well, where's your clinic? Well, see, it's this table right here. And just disregard the small child screaming because they're getting it. You can block it out, and if they go someplace else to Wyckoff or
Maybe you should be asked to put on the sixth, what is it, the new sixth floor of the med center that's not full or something like that?
Yes. Yes.
It's a big empty
Yeah.
floor.
Once again, I consider myself a foot soldier, so there's all these things that I'm not party to, but I know there was a big, so where we have our clinic, right across the hall was this big sort of clinic space that was sitting empty. And we'd go over there and go, wow, look at that, there's like 7 rooms in a big space, it's empty, oh, that belongs to, you know, it used to be, 3 years ago it used to be somebody, but it's been empty for 3 years, and it's like, you know.
Can we just borrow it until
Or
you
like-
rent it?
And
That's
so,
what you could say.
we actually, we started like asking around, and then someone come, yeah, you could go over there, but then someone else heard like, no, we want that, and it was,
Oh,
go-
no.
it was gone.
They filled it up.
Yep, it was gone. Oh, never mind. It's like,
And you won't stop fussing.
so space is at a premium, so, so I don't understand the big picture, but all I know is the other most important person in our little group is a person called Shara. She's my personal handler. And she's also, she tells me where to go at what time, so I just,
Just do what she says.
but
You better do
she,
what
to
she
me,
says, too.
she's the one that sort of holds the whole place together, and even more important, she's the portal that all the parents meet, and it's not often you have a person where parents come to you and say, oh, I love Shara, you know, because she's got such, that's hers, so,
She's like that manager.
yeah.
She's a-
But, you know, they've got her in a closet, you know, down in the clinic, right next to the screaming babies. You know,
There's a reason they're screaming when they're getting their shots, you
Yeah.
know. I mean, I saw mine turn blue, and she was only 12 months old, and she was probably I took her in there because she had been sick and was on Tylenol. 12 months old, MMR. Oh, while she's here, let's give her the MMR shot. Sorry, but, you know, I'm just saying.
oh yeah, I mean, they're screaming for a reason.
They're trying to scream and let people know that this is,
Yeah.
But
No,
but that's where Shara sits, and so on the one hand, space and more people, those are the two concrete things. On the other hand is, how do we want our government, or the people that control the purse, how do you want them to approach things? Where do you want them to put their priorities? Because one of the things that is very frustrating to us is, so for instance, if we have a child under the age of 3 that comes in, say they're 2, and they come in, and even though I say developmental behavioral pediatrician is harder than it looks, I also tell people it ain't brain surgery. I shouldn't say that, it's not rocket science. Because you have a 2-year-old, you can walk, a lot of the patients, you can walk in the room and go, oh, the child has autism. Oop, that took 30 seconds. Didn't take a multidisciplinary, you know, thing. It took just a couple minutes to figure that out. Okay, this is what's going on. This is what we need. Well, let's go to first steps. Oh, well, you're going to get speech and language therapy for 1 hour once a week. Okay, what else? That's it. Okay. So, does that make any sense? Because what I tell people is our treatment approach is going to be specialized instruction. It's like teaching somebody Russian. So if I'm going to teach you Russian, is 1 hour a week, how much Russian are you going to learn? not a lot. So, who out there is going to say, oh yeah, that's enough. That's enough for that. We don't need any more than that. Any logical person is going to say, well, that's not enough. Doesn't take a rocket science, Ron. But that's the way things have been set up in our sort of run. And so, you know, what at the top levels has to change. So no, that's not enough.
Well, it's like at school, they say that 30 minutes of speech therapy a week is enough.
Yeah. And so from the medical standpoint, I want to know is prove it to me. Show me the facts. Show me the studies that show an hour a week or a half hour a week. You see the same as opposed if someone got an hour a day. I literally got my hand slapped. Have my hand slapped because if you take the Institute of Medicine recommendations from 13 years ago that a child under the age of 3, they should get 25. This is written in black and white. Should get 25 hours of direct services. And so when I put that in a note once, no, the school's going to decide that. Oh wait, I'm going with the textbook. I'm not making this up. This is what the textbook said. No, we're going to decide. And so somewhere along the pattern's been, okay, 1 hour a week. So how do we change the approach at the big levels?
Are there people doing like evidence-based research type where you would have one person, like a group getting 20 whatever hours a week, 25 hours a week versus one a week?
Oh yeah, so I think it's already
been done.
It's already been done, and it's like it's not rocket science.
But
If I'm
you
going to
can't
teach
pull
you
it up.
Russian,
But you
is
can't.
1 hour a
Right.
week. How much Russian are you going to learn?
Well, I know, but that would take common sense, and that's not common. They don't look at common sense
Yeah, no, they're looking
ish
about.
ways in the government.
Yes,
I mean, they
but-
just don't. They'll spend money like that for something really stupid.
But the difficulty is $1 spent up front is going to save $10 down the line. So, but how? But that's coming from the powers that be, I guess, up here. So, and I don't. So something, would have to change, I guess. But I guess you have to vote the old guys out and put in the new guys. But
Well, it's going to change, but it's going to get really bad and ugly, and people are going to die, unfortunately. I mean, really, seriously.
well, it's already.
I mean, it's already
done.
happening.
So what was the article I gave you today?
Oh, about, there was this US News or, but they had the top 10 counties in the country for,
For the unhealthiest counties in the country.
And was Fayette in there?
No, but
but Kentucky had several
Yeah,
counties,
Kentucky would have
and
out
those-
of the 20, I think Kentucky had 10.
so,
They didn't quite beat out the Indian reservations in South Dakota, which if you've ever been there, it's like, oh my God. So they won the top spots, but ooh, look, Kentucky. Ooh, another Kentucky. Oh, look, another. Oh, West Virginia. Oh, Kentucky.
Is there
Did we beat
any
Mississippi?
models in the United States that you feel are working well? And what about looking at like models in Canada and that kind of thing? Is there anything there that you think is working well?
So I can honestly say I don't know, because I came from Amesbury Falls, Vermont, via South Burlington, Vermont, and then came directly here. So I have not had the opportunity to tour or research other centers. The only thing I get it sort of is if I go to a national conference
Yeah.
and I listen to my colleagues, and so like the guy that's sitting next to me, and, oh yeah, in Denver it takes 2 years to get in to see somebody, and the person in Texas is, yeah, I'm 150 dictations behind. It's like, okay, I guess it's not the, I'm not the only one pulling my hair out. So there may be systems out there that are working, but
That's what I wondered, is there, like, are there states that it is working better? I mean, I've always heard the further south you go, the worse it is. Is that true? I mean, like Kentucky.
I don't know. I saw some pretty scary things from New York when I was in
Really?
Vermont. And people were, and for the people that we were working in Vermont, we weren't, oh, this is great. We were like, oh. But we had people, yeah, we moved from Utah because we heard Vermont was the best place to, he's like, you moved here?
Really?
And it may
What
certainly
about
have been,
Wisconsin?
it may certainly have been better. And well, one of the slides I sometimes show is how, and this is just based on not the developmental behavioral pediatricians are going to make a big difference, but the one I have from I can't remember if it was, I think it's like 2009 or something like that. There's 3 or 4 states in the United States that have no developmental pediatricians, none, 0. I think at the time Wisconsin was 1.
West Virginia just has one.
So there's states that have 0. Actually, Vermont had the highest concentration because they had 4. But it's such a tiny space, and it's like, oh, geez, we must be stumbling over each other. But there's, I mean, 1 out of 5 children is supposed to have some sort of special need.
And what's interesting is, just like those of us with older kids, how we're kind of entering the whole world of life after school and housing and employment, where there still is this similar size numbers, that we represent with the itty bitties. They're still, coming through the pikes, at a pretty, like the incidence rate,
Well, we're getting 40 to 50 referrals a week. I would say 90% of them, when we look at the referral form from the parent, and I'm not a big researcher guy either, but this would be an interesting research question. Of the 40 to 50 kids that come through, 90%, the parent has a question, does my child have autism? In the end, and sometimes that is mirrored by the pediatrician that's referring them. In the end, I would say less than 10% have autism. But all those kids are showing up because there's some sort of concern, whether it's speech and language, or motor concerns, or sensory concerns, or some sort of behavioral concerns. So one of my big concerns is those concerns are just as valid whether they have autism or anything else, because those are impairing quality of life, impairing independence, and so it doesn't have to be autism to be significant. But that's a huge question mark. Why? And part of it is driven by, well, if it's called autism, at least there's more of a understanding or support for that, versus if you just say it's an intellectual disability or if they have ADHD.
It's a sexy thing right now, the autism diagnosis. you know, we're the hot topic. I remember we have another son with another kind of disability, and I listened to a webinar, and the speaker was saying, well, you know, this disability category is just as prevalent or more so, but it's not getting the attention or the, you know, the notoriety or the funding, you know, that autism is. And that's the kind of stuff that, you know, it breaks your heart, because that family with that child is, you know, just as concerned as we are about our loved ones, you know, trying to make sure.
Yeah, if we took all the kids that we see that are the products of a mother that was addicted to drugs and that, or alcohol, and now are showing up in our clinic because their frontal lobe doesn't quite work as it's supposed to.
Right.
Is that a pretty large percentage, you're saying? Wow.
That's a huge percentage.
Was it more alcohol or more like narcotics or illegal drugs?
Well, the hard part is you're never going to get a straight story.
Yeah.
It's the parent.
Yeah, I guess you can't once the baby's a day old.
The other
you
thing
can't really
is,
say.
so many of those kids we're seeing are being taken care of by the grandparents or adoptive
Right.
parents. And we see that all the time, so we have these people that, oh, I'm going to adopt this child, but serious things went on during pregnancy. Once again, this would be another interesting research thing, but if you come into my clinic and say, oh, I've adopted this child from Russia, I can immediately go, oh, don't tell me. Okay, so they don't sit still, they pull the dog's tail off, they have tantrums, they're emotionally labile, they can't focus, they're aggressive. It's because so many of the kids in Russia that are adopted, they come from families, they have a huge alcohol problem. Alcohol is very, very bad for a developing brain. So they come from a mother that was using alcohol. They were put in an orphanage where they were touched 2 or 3 times a day to change their diaper and fed, but that's it. And now they were adopted age 6, 7, 9, 10 months, and by a loving family, like, we're going to raise this little blue-eyed, blonde-haired Slavic child, and he's going to be a little angel, and his frontal lobe doesn't work very well. And I've seen that happen over and over and over. And then there's articles that basically those kids are often classified as pseudo-autism because something's not quite clicking socially, and they have all these other issues, and so it's really, but is it from the environmental experience, or where's it coming from?
So how do you know? I mean, like with my granddaughter, she has multi-diagnosis. She has the ADHD, autism, sensory, and intellectual disability. So, and they labeled it in Louisville NCDD. And Dr. Glazer here said, well, we call it autism in Lexington. I mean, so how would you know?
What's MC?
What the difference is? Multiple complex develop. Have you heard of it?
Yeah.
So why, is that just a subtype of autism?
No, so people are struggling to figure out what to call things. And the reason they're struggling to figure out what to call things is because if you can call something, then you can study it and figure out where it came from, why is it, and what are you going to do about it. And so what you've seen over the years is people trying to figure out what to call things, because then we can study it and try to figure out what it is. And so that's why Asperger's got tossed out, is because it got so, everybody has Asperger's. And trying to study it and to figure out what it is and what you need to treat it, what specifically works, it was too broad because everybody was being called it. So they're always trying to find ways of how do we find out what to call it, and this is from a medical aspect, so we can figure out what's causing it and how to treat it. So a lot of these labels are way too broad and not very specific. And this is strictly from a medical, not a educational, not a coding for billing, from a strictly scientific. So when someone, so we're going to be going to what are we going to? Conference. I knew it started with a C. In a few weeks, and one of the things is going to be about autism and sleep. So I pulled all 600 articles that I have on autism and sleep and started reading through them. And so everybody's done all this research. Well, kids with autism don't sleep. And so this one says, oh yes, high functioning autism and low functioning autism, they have the same problems. And you read this one over here, no they don't. Low functioning has more problems. Melanie brought me an article today about kids with normal
normal IQ, and that was like, I think anywhere from
70 and above. So they're saying, well, that's normal. In my world, 70 is not the same as 80, it's not the same as 90, it's not the same as 100. So when you say, lump those all together, it's hard to figure out, are we doing the right thing for this kid versus this kid? So we're still in the process of figuring out what to call these things and how to define them. And so once again, one of the reasons it's harder than it looks, it's still very subjective because everything's based on behavior. So you can have 5 doctors or 5 providers, and we can all sit and watch the same kid do something, and at the end we're going to say, so what do you think? And one was going to say, oh, he was totally normal. The other one's going, no, he wasn't. And the other was, well, he was sort of sometimes, because it's still very subjective. And anybody who says it's not, I think is full of baloney. And so the problem with, like, the gold standard tests, the ADOSs and it's still subjective. And that makes it, once again, difficult. One of my favorite slides is from the Autism Treatment Consortium or something. So you take like 12 of the big centers around the country, so the San Francisco and Boston and Cincinnati and Vanderbilt, and you look at the kids that come in and are evaluated, how many of them, and this was a few years ago, how many of them were diagnosed with autism, how many of them were diagnosed with Asperger's, and how many were diagnosed with PDD-NOS. So if you believe that the whole population is the same, so wherever they go, these should the percentages should be all the same. And it's not. Oh, this one, everybody's PDD-NOS and nobody's Asperger's. This one, everybody's this. It's all over the place. So it's subjective, and so that makes it dicey, because you're going to go someplace and they're going to say, well, your child has a sensory processing disorder. Well, you're going to go to this person and they're going to say, well, now they have ADHD. And you're going to go to this person and they're going to say, oh, now they have autism.
Really?
And my argument is,
And nonverbal learning.
yeah. And so my argument is, quite frankly, it doesn't matter what we call it. What matters is what are we going to do about it. And so you look at the child and determine what are the issues, and then you address the issues. Because you're not addressing the diagnosis. Because if I say, oh, that child has, if I say, oh, everybody in here has a child with autism, they're all different.
Oh, yeah.
That doesn't, and once again, that's where the classification system sort of breaks down, because when you say autism, so you could be Sheldon from Big Bang Theory, or Rain Man, or Bill Gates, or you could be all over the place.
Or a murderer, or the kid that shot up, you know what I'm saying? They're putting...
That's not a medical diagnosis.
But
That's
what
not a
they're
DSM-5
doing,
diagnosis.
what was the last murder deal they had, where they put that this guy had Asperger's syndrome up on the screen?
The one that shot up the school, right?
Who was it? No, but it was last
Just
week.
go in Connecticut, oh.
But there's only one thing
But
almost
I'm just
as
saying,
evil
you're
as
sitting there
insurance
watching
companies
TV and they're putting that up there.
is the media. So the media is just, because right now the plane crash in Germany.
It was the big real estate guy. The Durst.
Oh, I haven't paid attention to him.
He's old and
But
So that's his diagnosis?
the
I got that.
the pilot in the German air crash, oh my God, he's depressed. Uh-oh.
and he's probably going to have Asperger's
So-
too. They're going to put
well,
that up there pretty
So,
soon.
and he's on medicine. Uh-oh. Should I resign now, or? So, but they're every day they're just flogging it. Oh my God, he's gone to 2 psychiatrists. Oh, well, I've been to 3. What does that mean? So the media can.
Yeah.
Yeah,
Do
they do.
harm.
They put the flavor on it.
Did you say your buddy's done something, was it called Orchid?
Okay, so yeah, so my 2 foundations for, to me, a developmental behavioral clinic is the governmental model, and the other is the orchid theory. So what the orchid theory is, and this was in an article 4 or 5 years ago in the Atlantic that I stumbled across. And basically it's a genetic theory that, usually in genetics, if you have a bad gene, everybody goes, oh, that's too bad, you're prone to depression or whatever. But there's a sort of an alternative theory that, okay, there's a reason those genes are there. And so what the theory says is, well, most individuals are dandelions. I just gave this speech in India, so most people are dandelions. Do you have dandelions in India? Give me a weed that you have. But most individuals are dandelions. Dandelions are very adaptable. They grow everywhere. You don't have to do much. They grow on your front lawn. You don't have to do anything about it. They grow in the parking lot. They grow in hard-packed soil. They grow on mountains. They're everywhere. Well, there's individuals that are more like orchids. Orchids are very finicky. They're not adaptable. They're very snarky. They have to be in the perfect place for them to blossom. If they're not in the right place, they just sit there and don't blossom. I can't get an orchid to blossom if my life depended on it. My brother and father, they have orchid flowers, everything. But this is the genetic theory that says, well, the reason the human species is successful is because of orchid people. They're snarky, they're not adaptable, they're rigid. They need a special greenhouse. They need a special environment. But the theory is if you can find that environment, they not only have the potential to blossom, they have the potential to excel. And so the reason the human species is successful is because of orchid people. They're snarky, they're rigid, they're not adaptable, they're a pain in the butt, but if they're in the right greenhouse, they go on to do amazing things. They invent this, they design this, they compose this. So you can sort of go through, to me, Robin Williams was the ultimate orchid. if he wasn't in a very specific environment, he wouldn't have lived out of high school. If anybody saw the movie that just was out, The Imitation Game, with Benedict Cumberbatch or whatever his name is, Turing. So he's the one that basically invented the computer. He was an orchid. He didn't quite fit in. So I consider my patients orchids. One of the main approaches is we have to figure out how to build a better greenhouse. Schools are made for dandelions. But the hard part is schools aren't very flexible. And the other thing, if you have a child that's an orchid, we're not going to turn them into a dandelion.
No.
They're an orchid. So we have to figure out how to sort of embrace that and go with it. I mean, we still want to try to figure out how to teach them to live in the dandelion world, because the world's for dandelions. But we don't want to lose that they're an orchid. And so many of the kids that we see is, oh yeah, they have some talent or trait or something that, ooh, we need to figure out how to fertilize that. But that trait or talent is not valued in the first grade. We don't care about that. You need to sit in circle and we're going to talk about adverbs. Well, that doesn't.
Or if you get up and move around, we're gonna probably restrain you,
Yeah, so,
put you to the floor
yep, you have to have
for the next
both.
15 years.
You have to put your feet on the ground and
Yeah.
crisscross applesauce, and
Yeah.
so the hard part is how you build a better greenhouse. So, for instance, so my kids that have ADHD, if the last time I went to a big conference, if we wanted to design the perfect classroom for a child with ADHD, it would be small, 10 to 12 kids, be multi-age, so that the child would have role models that are older, and also have younger kids that he would be the role model, he or she would be the role model for. Each kid would have their own curriculum. Not everybody's doing the same thing. You'd sit down and go, okay, what is this kid? Where is this kid? How does this child learn? What works best? What are the strengths? What are the weaknesses? You're not just going to, you're in the third grade, everybody's going to do this. You have frequent breaks. Oh, after 20 minutes, go out and split wood. Oh, go get water. So basically what we're described as a one-room schoolhouse.
A Montessori classroom.
Or a Montessori classroom.
Right.
That is what you just described.
Right. So, and that's been scientifically proven. So that's on my list of things that have been scientifically proven to improve executive function.
But
So-
they don't take the orchids anymore, a lot of times. They
Right.
don't take the real specific orchids, the Montessori schools
Well,
will.
they take some kinds.
Especially if they aren't potty trained by a certain age.
But that was brought up at a big conference I went to, that, yeah, if we wanted to build it, but that's not how the modern classroom is. The modern classroom is, everybody's got to follow a set curriculum, and then we got to meet these certain standards, and you got to do it a certain way. And, oh, by the way, you got to show your work, because we don't want you doing it a different way. Everybody's got to do it the same way. But that's the orchid theory.
That's good.
And then when you start talking about having a school just for the orchids, then there's, kind of negative response to that, because, we want to be inclusive, and have everybody. So it's daunting to figure out, how to help kids, because sometimes they go back to communities where there's not a lot of, like Lexington compared to some other counties in the state has so much more, like our Parks and Rec program and the we have all these additional things in tandem to, the school district. But some counties they have those kinds of things, you know, so they're only, the only resources they have available are maybe the comp care system and the school district.
Right, they don't, and they may not even have therapists.
Therapists.
Like occupational and speech therapists
Yeah.
are most basic of services to many to choose from.
Yeah.
Right, which our county doesn't. I have to come to Lexington for
So
everything.
you have to come, okay.
I have to come here for everything.
Well, and, because I always thought, there was a couple of times where there had been some, and some of the counties that he has patients in are very rural, so, you know, it's difficult to get to someplace because of the terrain and all that kind of stuff, and so, oftentimes the family's asked to drive to the clinic, the hospital, the whatever, you know, and it's very difficult, and especially with this last bout of really bad weather, you know, there were like, you know, 1, 2, 3 weeks where there wasn't any school, there wasn't, you know, any services, and think of that, how, you know, how isolating it feels when you're at home, you know, there's no school, and you're trying to, you know, help your child or your youth to have a good life, you know, and but school's been canceled or whatever. I think about if you're in the, you know, really rural kind of areas where there's not much to begin with on top of everything.
School's canceled for weeks.
And weeks at a time, you know.
But one of the things we bump heads with sometimes is, well, that's not fair. You know, like this, well, I don't think that child should have homework. Well, that's not fair, everybody's gotta have one. Fair is not equal. Fair is everybody gets what they need. So that's a difficult philosophy for people to wrap their heads around or to address, because once again, it's gonna be real subjective. But we run into that all the time, that, oh, you're in the 4th grade, everybody's gotta do the same thing, because it's not fair that the student gets this or that. It's like, you know, you gotta, once again, you're trying to build a better greenhouse, and each child gets what they need. That's what's fair.
Let me ask you something. I come up here to UK, I know, I go to the Child Development Center for my OT and my PT, you know, go several things, and I've been to UK speech with my son. Have they ever thought about putting like all these service, I mean, I know you're talking about building something big, but you know, they built that big Child Development Center. The OT and the PT, that's all in there, and they've got some speech, I think, in there too now. So why don't they put a doctor in there too, so you could just have like all of that together? So you wouldn't have to, because I have to go like, I'm not kidding, I have to go to a psychologist on North Broadway, then I have to try to get, I mean, I do everything in one day. When I come to Lexington, I do it all one day. So it's like, it takes me 25 minutes to get 2 miles or 3 miles, like across to child development and all that traffic. So I'm just thinking, why do they not, UK, think of putting all that together for parents, because it really, I mean, I'm sitting here in Lexington for 5 or 6 hours as a parent.
Well, I'm gonna answer part of it. Child Development Center of Bluegrass was an independent organization
Right, but
before
they're part of
UK
it
asked
now.
them to, when they partnering, so they were like the United Way agency with their own funding stream first. And I think that's what, like what you said, that made it kind of a more natural fit for them to go over there. But I think that's probably why that's why their, their model has been in existence since the 60s, late 60s is when they started as a school for children with cerebral palsy. Oh yeah, I have one of their chairs in my garage. It's a little wood school chair. It says Child Development Center. It says 1969.
Wow.
They sold them. So.
But when they did go in with UK, I mean, they built that huge center.
Yeah,
So I'm
they're
just-
collaborating.
Right, so I'm just saying, I mean, they do a lot of autism work, I know that.
Yeah.
And so I'm just thinking, why do they not go ahead and, I mean, it's huge over there, they have a lot of
It's
area,
really
a lot of
beautiful
land.
building.
So,
You're saying they have a space for his offices.
I'm saying they could build all kinds of space over there for your office.
They
That's what
just
I'm
take
saying.
up Just
Does
take out
UK
that
own that
overflow K
building?
lot.
I
Yeah,
don't know.
There's a
Yes, I
UK
think
parking lot right next to
think
it,
they
you can
do.
overflow and
Does
build on.
UK owns it?
Yes, because when they moved, they told me that UK was, it was a part of UK. They were
It's
going
UK's
to UK,
property.
Yes.
And they give preference as far as I understand, in terms of enrollment in their preschool to UK employees
Right,
now.
right.
Whereas it
So
used to
it's-
just be anybody who wanted
It's
to
all
go there.
UK based. I
Did you know
mean,
that?
that's what they told me now.
You make that
Like my
face.
insurance and all goes through,
Do that.
yeah.
I can see that that would,
So I would
Fit
think
for a-
that you would check into that.
I don't know,
See that
behavioral
I'll do that.
pediatrician.
yeah. I think the answer to that is,
I made that
it's,
suggestion already.
it's called trying to herd cats. So it's a huge organization. So there's all these different parts that are doing their own thing, and they don't talk to each other.
Right.
And they're, I mean, this is a small town guy coming from, you know, my one little practice with my one little, you know, handler that, wow, if we wanted to buy a new doormat, go buy a doormat, okay. As opposed to here, if we're gonna buy a doormat, it has to go we have to go through 3 or 4 committees and then get it signed off, and then we gotta get a voucher to do this, and it's like, forget it, I'm gonna bring one in from home. So that, to me, has been, I guess the word's eye-opening, because you have all these big entities but they're not talking to each other, and when they do, they're very, you want to take over my space? No, you can't touch my space. An example was, so I was talking with Harold Kleiner, and he was telling me how 2 of the largest advocacy groups for Down syndrome in the nation are here at UK. And, you know, he showed me this article, and at the end it said, oh, you know, these are some of the, you know, nation big advocacy things, and those 2, those are UK. I go, oh, that's cool. So, so does the geneticist know that? That's next door, and his genetic counselor, and he goes, they have a genetic counselor? So I go over, do you know
No
that
way.
the 2 largest advocacy groups in the nation are here at UK? There are?
Give people-
So-
That's a good idea.
So there's not a lot of lack of communication. On the other hand, there's been stirrings in the last 6 months of people trying to get together and like get organize something together, but it takes, I think it takes a certain amount of inertia or critical mass, because there's so much other stuff going on. Like, we're building lots of dorms, and we're fixing the football stadium, and we're building a, you know, Shriners Hospital over here, and we're gonna move this. So there's a lot of stuff going on, but there has been movements in the last 6 months where some of the big powers have gotten together and trying to figure out how do you develop a center for autism excellence, or whatever, something like that. But it involves pulling in College of Education and College of Psychology and the medical part and OT and speech and language, and it's like herding cats. So I
Who is
think,
behind that push for the Center of Excellence?
I think Dr. Vogel
Lisa.
and I think Dr. Kleiner. Well,
Great.
Maybe, what's the other, Lisa Rubel's part?
Oh, John.
John Campbell.
Dr.
John
Campbell.
Yeah.
Well, there's something called the Len Grant.
Yeah, like University of Cincinnati.
Yeah, so there's something called a Len Grant, which is a big chunk of money. It's that goes to certain centers around the country. So it's a big, but it's competitive. So you have to compete for it, and so each state gets one, or I don't know, I'm not sure. But you have to show a level of collaboration to get the money, so you have to show multidisciplinary collaboration. So I think there might have been one here many years ago, but then they lost it. But they sort of they was like, ooh, if we can get this together, we can get a LEN grant. Once again, it provides.
I'm just laughing because it's exactly what you're saying. If there were a funding stream, we'd be able to do it.
Yeah, so
everybody
so
wants
trying to
that
get
funding.
everybody together on the same page and
So they need to get buy-in from those other schools to even present.
yeah, and so you get, yeah, so you have to get like 37 ducks in a row, and you have to get 15 of them standing on their left leg, and then the other 16 have to stand on the right leg, and so, because we've had a couple meetings with Dr. Glazer and Dr. Rubel and Dr. Campbell, and then people are going to talk to, people at the, other levels. But if it moves, once again, I'm new to these big systems, so if it moves on how I've seen things move, it'll be early 2056 when it'll kick in.
Yeah.
But there has been, like people have said, there's been a lot more in the last year rumblings. The question is, how can organizations like this, or populations of parents and or interested folk, create enough critical mass to like get someone's attention at the level that needs something to be done, that go, oh, okay.
Who is it who we met with? We've met a couple of times at the Med Center. Dr. Pearl.
We met we met with Dr. Perman, and then we met with Dr. Karp a couple of times, just trying to ask the questions, like, how do we go forward, to
Yeah, how do you get enough critical mass?
Well, we
where-
were going in there and saying, look, we're your customers. We have all these people who are your customers, and they come to us as the Autism Society and say, we don't know where to go.
Yeah.
And so we were going to them and saying, can you help us find a way to know where to send your customers? That really is the conversation we had. We have all these people, like what you just said, who need speech and occupational therapy and ABA and, all these different treatments, and it is not uncommon for parents to come here and say, who do you use for an occupational therapist? Who do you use for a speech therapist? And for me, my kid doesn't go get her therapies at UK, but for me, as having a huge organization like UK, it's ridiculous for them not to see this group as customers
Yeah.
that who could bill, they could bill for, not just serve and help, but also as a funding stream for them. And that is the frank conversation we
But
have.
it's very competitive, because there's other groups or other entities out there. So for instance, the UK is going to have a forensic pediatrician soon.
Really?
What is it?
Because of the,
So that's addressing child abuse.
For criminal.
Yeah. Because
Is there that many to justify a whole job?
and for instance, we could probably have our own fetal alcohol clinic.
Oh, good, you'll be in charge of that too.
So it's very competitive, and once again, if you take all these groups, someplace, someone's going to make a decision. What group is going to generate the most revenue?
So one of our things is that there is no place in Lexington to go if your child or adult person with autism has a breakdown in behavior and are out of control. There's no place, nowhere for them to go. If you call the police, they might say, we're going to taser you, we're going to take you to jail, and they become a criminal. If you call the you know, the paramedics, they will take them to Good Sam, and then they call the parent to come back and get them in an hour or two. And so there's no place to go, and we've had this experience, and so we're trying to get like a calming room, and they're saying, we've gone to like we need a safe crisis. You know how autism is like the flip of a light switch? You can be, my granddaughter, she had great behavior in the hospital, having a video seizure monitoring. For 2 days, she was perfect. But she was sitting in a bed, playing on her iPad, being calling room service, and she loved it. And then when it came time to go home, because she wanted to go to the hospital. So then when it came time to go home, and she said she was ready, and they took all that stuff off, and I'm getting ready to take her home, and she's like, I don't want to go home. I'm going to kill Granny. I'm going to do this, and and just totally goes ballistic. And so I push the nurse, push the nurse's thing and say, I need help in here. And they come in, 10 people come in, restrain her to the bed, restrain her with this, restrain this, put gauze on her, with her screaming and yelling, and they take her out of that place and put her down in CCU because that's the only place they could figure out where to put her. The neurologist comes in, he just kind of is like shaking his head because he's seen her like perfectly behaved, and he has no clue about what to do. And so they're calling Our Lady of Peace, and I'm thinking they're going to make me put her in Our Lady of Peace. So I spend the rest of the afternoon, and they give her 4 milligrams of lorazepam and Halidol or something. So by then she's like, whatever, and they've still got her restrained to the bed. And so we have to spend 2 hours, waiting for someone to come from Our Lady of Peace and explaining to them why she doesn't need to go. And they're asking her if she's still going to want to kill Granny. Now she doesn't, she's saying that, number one, because she's been restrained all of her life in school, and she likes it because it's deep pressure. And also because, it's just crazy, but they're making her tell them that they're not going to take her if she says, I'm not going to kill Granny.
Well, you're also talking about someone who you yourself said has an intellectual disability, autism, and other diagnoses, and that's almost a silly question to ask somebody.
Well, but this is our
like, does
Our
she
Lady
even
of
know what it
Peace.
means to kill Granny? Really
No,
and
she
truly?
doesn't, but why
Right.
are they asking her that, and why would they want to take her? I had to convince them, and we did.
So the problem, crisis beds or crisis placements,
Stabilization.
are very expensive, and so that's a huge deficit that I see coming from, not that Vermont was all that much better, but it's such a smaller state. But we had something called Brattleboro, which, it's all the way down to the southern part of the state. It's an hour and a half away. Oh my God. But to have emergency beds available, they have to be staffed, and so once again, it's an expensive proposition. But there's a huge lack of places. What do we do with, and and it go, but I think the answer is across many different domains, what shouldn't psychiatry, shouldn't that, be in charge? But for instance, we get referrals all the time from kids that they can't get in to see psychiatry because they won't see them if they're under 5.
Really?
Yeah. So, well, sure, send them, we'll see, take a number. But, so there's, so across the board, there's a lot of gaps. And so, how is that gonna change? What's gonna change from above when people change their priorities?
It's gonna change when enough of the kids get killed. I'm sorry, but it is. And mine is not gonna be one of them because I'm not calling the police. I'm not calling anybody for help because that's what they wanna do. They wanna take her away and they're quick to do that. And they wanna take me to jail if I tell them not to taser her. And I'm just not dealing with it anymore, but I'm telling you, there's other parents, there's other people, there's already been one, Roland Campbell, 18 years old, who I believe he was killed by the police. I believe it. I believe he was tasered or smothered or something, but his life wasn't valuable enough. And I'm just saying, that somebody's kid or grown up or somebody is going to happen again, and then maybe somebody will take notice. I don't know. Only if it's somebody that's, in politics, they're kin.
Wealthy.
They're wealthy, and that's exactly what's going to happen. I predict it. Sorry, but that many kids, and for us to go to Good Sam and be released. And for them to tell us that this happens all the time and we don't have any place to send these people. It's sad. In Lexington, we've gone to the mayor's commissioners group
For disabilities.
for disabilities, and they say, oh, you do have a place. They have a calming room over at Good Sam. Just because they can, just because they say they have it doesn't mean that they have it. So anyway. I mean, this is, we need to stand up and do something.
Yeah, so so on one hand, until you get the people at the politicians or whoever who vote the money or set the priorities, so that's.
I've always thought if we need to have a community meeting and invite, somehow advertise it and invite the people that care about somebody, somehow have a person somehow involved in their life. And I've heard Dr. Larrow talk about it too, where you just have a community meeting to talk about the state of the state, or the state of our community, and where do we go from here? Community conversation, but just to kind of, get the word out and begin to have a dialogue about it, because I think, especially, I guess I hang around with people that have kids of similar age or young adults of similar age as our son, and I hear the concerns about there's no, where am I going to have my loved one live? We've got a plan in place, but I don't know if this is going to work out. I've got X amount of years before I pass on, and you hear stories like that where people are really worried about, what's going to happen next, for this population. They're coming in to this part of their life, and we're not ready for them. It'd be so awesome to be able to have a conversation with people that have the ability to make policies and laws and generate funds or whatever to do something, in response to those concerns. I think that would be really powerful.
Dr. Larrow, thank you for being
Thank
here.
you so
Yeah.
much.
We really appreciate it, and do let
Yeah,
us
we really
know
do.
if ever we can get out information for you, if you have an event that, or if you need any help at all. You think of any way that we can help, we have a
Well,
big
yeah.
listserv, so we can put information out, that's one thing we can do.
Well, if you, like I believe that if we, it's such a complicated and the breadth of the complexity is all over the place, but if you can get a critical mass on something that's concrete, so if someone somewhere can come up with a concrete, oh, this is, something we can do to get a critical mass, whether it's at the med school level, or the university level, or the city level, or the county level, or the state level, then that's where everybody can sort of hopefully come together and create a critical mass. The hard part is getting something concrete and, once again, getting that critical mass so somebody will listen.
If you all ever come up with the concrete idea, I mean, we can help disseminate it. We have over 700 people on a listserv now. That doesn't mean they're easy to
They don't do anything.
put into action, yeah.
But
But we can
at some
still
point,
do
you were talking about setting up something at the university.
I just think it's timely, so to try to,
Because if and correct me if I'm wrong, but it had to do with employees. So
And what-
UK is huge. So we took the employees that had children with special needs, and everybody got together, and if you got whoever the heads of the hospital or the university or some in the room to hear it, and then they would hopefully go, oh, gee, maybe we ought to do something about that.
That's interesting.
but I think even now, I mean, that would be great, but I also like to think about just everybody, because I think that I'd love to get the university to kind of begin to listen to folks that work there
Yeah,
or
so-
students there, But I also think there's this whole other cadre of people that would be very interested to be a part of that discussion.
Well, you're right, it's timely. I've never, since ITEC went away, I've not seen so much activity around autism at UK.
Yeah.
Since what went away?
Infant Toddler Evaluation
Yeah.
Center, ITEC. So, I mean,
And you've got
It's Rugal and John
students
Campbell
coming to
and
the
Dr.
campus
Larrow. It's
that
really-
either have autism themselves or that have siblings or, some kind of family member that, so there's kind of this ongoing interest and passion because they've had a personal experience, they've been touched in some way, shape, or form. It's because the incidence rate, it is what it is,
that's right.
Well, thanks for having me.
Thank you for
Thank
being
you.
here. Appreciate it.